Welcome to my YouTube channel. Today we're going to talk about management of preterm labor. Kindly make sure you subscribe. It will cost you absolutely nothing. Management of preterm labor. The goals of therapy are four of them. Number one, you prevent preterm labor if possible. So you already know the risk factors. So if the risk factors are modifiable, then you prevent them. And there are also other methods at which you can prevent preterm labor. We're going to talk about them, primary, secondary, among others. The next thing is to arrest the preterm labor if possible and if it's not contraindicated. When you arrest is when the preterm labor has already started, so you arrest it so that it cannot progress. And then appropriate management of labor. So this is where you cannot arrest the preterm labor and it has to continue with its natural course. So this is appropriate management of the labor and effective neonatal care, where labor has occurred and already you have the neonate who is premature. So you have to do effective neonatal care. So why are we doing, or why do we have these goals of therapy, which include prevention, arresting, and ensuring good progression of labor, and also appropriate management of a neonate? This is to prevent complications of prematurity, which include respiratory distress, intraventricular hemorrhage, bronchopulmonary dysplasia, patent ductus arteriosus, necrotizing, necrotizing enterocolitis, retinopathy of prematurity, and sepsis. So how do we approach in terms of management? Just to remind you, we say the period of preterm starts at 20 weeks and 37 weeks, 37 completed weeks. So we are going to divide again these pregnancies again according to the gestation age. And the patient who comes in to 34, that when they're beginning 34 weeks to 36 and 6 days, weeks of gestation, then you advise the patient or you proceed with normal labor and delivery. However, if the patient comes with less than 34 weeks of gestation, then you consider tocolysis to inhibit uterine contractions and then administer steroids for lung maturity and prevention of neck and also the intraventricular hemorrhage. And you administer antibiotics for prophylaxis of PROM, and in addition to that, for prophylaxis of neonatal sepsis later after the neonatal during the neonatal period. And if a patient comes with less than 32 weeks of gestation, you consider magnesium sulfate for fetal neuroprotection. Role of tocolysis, as we said before, tocolysis that is administered to inhibit uterine contractions. So in the case of premature rupture of, in case of preterm, it allows us to administer corticosteroids and it allows you to transfer the patient to a tertiary care. In addition to that, it's also used during maternal antenatal surgeries, and it is important in terms of uterine relaxation in external-cephalic version. So the drugs that we use, just say it is not my time, and I for indomethacin, so which is an NSAID, and for nifedipine, which is a calcium blocker, M for magnesium sulfate, and T for tabitan, which is an adrenergic agonist. So the tocolytics, as we just say, this is just a repetition. The beta agonist, which you say tabitan, these are the doses, and then magnesium sulfate, the doses, antiprostaglandin, which you said indomethacin, and then calcium blockers which is the nifedipine, or you can also use ritodrine. You can also use oxytocin antagonists and nitric oxide donors. So all this, their mechanism of action will later result to inhibition of the uterine contraction. Also, kindly note that in terms of prostaglandins and NSAID, it will, if it is used after 32 weeks, it will usually lead as a side effect, usually lead to the premature closure of the ductus arteriosus. Next, contraindications to tocolysis is when you have gestation more than 34 weeks, when you have significant vaginal bleeding, suspected fetal asphyxia, intra-amniotic infection, intrauterine demise or lethal anomaly, maternal indication, uncontrolled diabetes, severe anemia, cardiac disease, severe preeclampsia or eclampsia. Although the tocolysis may prolong pregnancy, they don't usually improve the prenatal outcomes, but do have adverse maternal effects. So these drugs usually have the normal side effects of the drugs and what they'll adverse to the mother. As a rule, they should be given with they should be given with the corticosteroids, and most do not recommend use of tocolysis, as we said before, in pregnancies that are equal to 34 weeks or are greater than 34 weeks. And then there is no role of maintenance of tocolysis. These tocolysis have to be given within 48 hours. So antenatal corticosteroids, if you remember, we said in pregnancies that are less than 34, we should administer corticosteroids, and the rate of corticosteroids is to prevent, for example, lung maturity and to prevent cases like respiratory distress syndrome, in addition to NEG. So it is given to all fetuses between 24 to 34 weeks gestational pregnancy who are at risk of preterm delivery and should be considered. So the decision should not be altered by race, gender, availability of surfactant replacement. Therefore, just give. Those eligible for tocolysis are also eligible for corticosteroids. The optimal benefits usually begin 24 hours after initiation, and then they usually reduce the incidence and severity of RDS, IVH, and NET. So RDS is respiratory distress syndrome, IVH is intraventricular hemorrhage, and NEC is necrotizing enterocolitis. I want you to remember those three of them. Those three of them. When you are given an essay to write, those three must be there: respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis. So the drug that we use is dexamethasone and betamethasone, which can be used. We are going to talk about the dosage in the next slide. So this betamethasone or dexamethasone, these steroids are preferred over other steroids because they are less extensively metabolized by the placental enzymes, that is 11 beta hydroxysteroid dehydrogenase type 2. So that's why we prefer betamethasone or dexamethasone. However, between dexamethasone and betamethasone is often preferred due to its longer half-life and potential fewer side effects. So in terms of doses, which we said betamethasone is the most preferred one because it has a longer half-life and less side effects. So the typical regimen is 2 doses of 12 mg, which are administered IM 12 hours apart, and then total you will have 24 mg. And then dexamethasone, the total dose is also 24 mg, and the regimen usually consists of 4 doses of 6 milligrams of dexamethasone given IM every 12 hours, and if you multiply 4 doses of 6 mg, 4 times 6 is equals to 24. So the antibiotics you also have to give, and it is given in all patients in premature labor are considered. So all patients in premature labor are considered to have increased risk of neonatal group B streptococcal sepsis and should receive prophylactic antibiotics regardless of the culture status. So if a patient comes in and even if the culture status is negative, or the culture is negative for group B streptococcal, then you still have to give prophylactic antibiotics. And the CDC advised screening of all pregnant women for group B streptococcus at 35 to 37 weeks. This should not be used to prolong gestation or to improve neonatal outcome in women with preterm labor and intact membrane. So the goal actually for giving these antibiotics is to the fetus it is to the fetus, and it's to prevent neonatal sepsis and not to prevent preterm labor. Remember, the only thing that we can use to kind of arrest the preterm labor is the tocolysis. And we say the mode of action or the result of the mode of action of tocolysis is to inhibit contractions. So if we inhibit contraction, at least it will give us time to give antibiotics and also to give corticosteroids. So delivery, tertiary care center is where you need to deliver these kinds of patients, and you need specialized staff and specialized equipment. The decision whether to do cesarean section or normal delivery, that is vaginal delivery, depends on the type of the patient or the characteristics that the patient has and the risk factors among complications that the patient has. However, CS may be preferred in extreme prematurity. The stages of labor will progress as normal labor, and during the first stage, you usually have the latent and the active phase, which will later result to the dilatation of the cervix. So you put the patient into bed, you ensure adequate oxygenation of the patient, you avoid strong sedatives, and then epidural anesthesia is the anesthesia of choice. Labor should be watched by intensive clinical monitoring, continuous electronic monitoring of the labor, and in case of delay or anticipating traumatic vaginal delivery, then a CS should be performed. In terms of second stage of labor, where we normally have now the delivery of the fetus, the birth should go gentle and slow, Episiotomy may be done under local anesthesia to minimize the head compression, and cord is clamped immediately at birth to prevent hyper. Because this baby is small, then if you allow blood to move from the mother to the fetus, you can have hypervolemia and hyperbilirubinemia to shift the baby to ICU. So care of the preterm, the cord is clamped quickly as I said before, and the cord length is usually kept long. The hair partial should be cleared of mucus promptly and gently. That is to enable adequate oxygenation, and then maintenance of temperature to prevent hypothermia. In addition to that, just as normal newborn, you inject vitamin K. One of our goals of management was prevention of preterm labor, and in terms of prevention, we are going to divide it into two, primary and secondary. So this is to improve the quality of life and nutritional status of the patient, and you ask the patient to reduce physical and emotional stress by encouraging bed rest. You have educational programs for signs and symptoms, and these signs to include contraction, pelvic pressure, vaginal discharge. Hydrate the patient, make sure the patient is hydrated. Progesterone, which is usually given in second trimester, especially in women who are asymptomatic and have a prior history of preterm labor. And cyclage, which is a procedure which is used to keep the cervix closed and is used to treat cervical incompetency. And diagnosis and treatment of infection such as UTIs, which is said is one of the risk factors, and role in assisted reproductive technology, twins and higher order multiples use. So secondary prevention, this is when already the preterm was already started and you're trying to arrest it. So what you can do an emergency cyclage. You can also administer antibiotics as we talked about in the previous slides, and tocolysis, which will prevent uterine contractions. Thank you.